So it's a pleasure to have Dr. Michael Cookson, who is the chairman of urology at the University of Oklahoma, and welcome to Bladder Cancer Academy.
Thank you very much.
So bladder cancer used to be the stepchild for uro-oncology, but now I think the greatest excitement in the field is around bladder cancer. So let's sort of start at sort of the beginning with detection. So typically you have microhematuria, and there's a whole cascade: imaging, cystoscopy, and so forth. So are we soon to see a evolving paradigm in terms of sort of screening for bladder cancer with biomarkers?
Well, I think that's an excellent question. I think the screening is a work in progress because it's a wide net to cast to find the number of patients that may harbor the cancer. I think where the urinary markers are really performing best right now is in high-risk patients, identifying those. So, for example, smokers and patients that have had occupational exposures, gross hematuria. Those are where the markers may be beneficial. And then certainly in management of patients under surveillance with established bladder cancers. You mentioned that it's kind of the stepchild, but really it's also been noted to be the most expensive cancer from diagnosis to death that we treat in urologic cancer. And so we have to figure out ways to do that better. A lot of those costs are associated with the procedures and the burden on the patient that we have to put them through to monitor for these cancers. And so the markers are looking at ways to try and detect these cancers and figure out if it's okay to not do as many of the procedures that we've traditionally done.
So give us an example of how you've implemented some of these urine-based markers in your practice.
So the best first example that I can give you, so we need to remember that bladder cancer non-invasive comes in many flavors. We have the non-invasive low grade and we have the high grade. Cytology performs quite well in the high grade tumors until you start treating them. Once you've given BCG and intravesical therapies, the typical cytology report comes back atypical. That's not helpful. So one of the best ways that we've been able to do that is using a marker such as a urinary FISH marker. It's a fluorescent cell-based marker that uses not just the appearance of the cell, but the genetics of the cell to highlight changes that occur, and it arbitrates for these atypical. So in fact, in many of our bladder cancer patients undergoing BCG therapy, we don't order cytologies anymore. We go straight to the urinary marker, and then that allows us to predict whether they'll need additional treatment, a biopsy, etc. There have been some studies, one out of MD Anderson, that showed that this was very powerful in predicting not only recurrence but progression. That urinary FISH marker that's obtained somewhere between their third and sixth BCG treatment.
So how about the horizon? So is there some excitement in the field that's near term, you think?
There's a tremendous amount of work being done because I think, we went from simple protein-based things that were relying on cell death to be detected in the urine to these more cell-based things, and now we're looking at the genetic components and being able to really parse together ways in which we can detect these tumors, not just high grade but low grade, and alter our surveillance pattern. Now the studies that need to be done are the studies that actually do take out some of those cystoscopies and we randomize them and follow them closely, because that hasn't been done. But we now are approaching some of the most important parameters that we need for these markers: confidence to the patient with high sensitivity and high negative predictive value. The patient needs to know if we say this marker is okay, there's a very high chance that nothing's going on in their bladder. And when we get that and we do the right studies, we will be able to ultimately reduce the cost and the burden on the patient.
So it sounds like most of these urine-based markers are, you already have the diagnosis of bladder cancer, and this may influence the timing of cystoscopy. How about, again, it's frustrating, and so many times a patient comes in microhematuria. It's 3 to 5 red blood cells in the urine. It's sort of like that PSA, right? And now you are compelled by the guidelines, right, to get a CT, to get a cystoscopy. Do you think we're ever going to get to? I shouldn't say ever. Are we moving to to have these urine-based markers where you can take someone with microhematuria and decide whether or not they really do need that full diagnostic workup, which almost invariably is negative, especially in the non-smoker?
Well, it's a complex question with a complex answer. Anytime there's hematuria, these markers are going to help, and they are getting better and better detecting urothelial cancer. But we still have renal cell carcinoma. These markers don't address that. There are other causes of hematuria that will be uncovered, and even benign reasons. So I don't know that we'll be able to omit imaging as we go forward, but I do think that the urinary markers are getting better and better at telling us who's more likely to have a urothelial tumor, who needs an investigative cystoscopy.
All right, so let's turn to another topic you'll be covering here at Bladder Cancer Academy, and that is advances in resection of bladder tumors. So first of all, is the typical urologist able to simply look in the bladder, see all the tumors, and appropriately resect the tumors, or is this a bit more complex, something that would be sort of like Urology 101? Do we really need tools to do better resections?
Well, we've always felt as urologists that we see the tumors, we resect all the tumors, but nowadays, incorporated into the guidelines in our clinical practice particularly, is the need for re-resections in high-grade patients, T1 tumors, patients with CIS, variant histology. We know from going back into the bladders of those patients that anywhere from 50 to 70% of the time we find additional tumors. So if that's our report card, we're not doing that well. And now we have evolved into some new technologies that also show us enhanced detection anywhere from, say, 20 to 30 to 40%, depending on what we're talking about.
So what are those new technologies?
So one is called narrowband imaging, and it takes advantage of the fact that when you shine a narrow blue-green spectrum, the blood supply to the tumors and the bladder itself are enhanced, and you can sometimes see these tumors that can be quite small on top of the surface where you wouldn't have visualized them in white light. That technology can also be used in the upper tracts because it's available in flexible as well. The studies have shown enhanced detection, which then translates into reduced recurrence when you apply that. So it's almost like sitting, there's a great picture of a raft, somebody floating on a raft in a green Caribbean Sea, and that's kind of what you see when it works well. And so that's narrowband. The second one is the use of sort of a blue light or photoporphyrins and taking advantage of that. So there's a product called Cysview, FDA approved in the United States. You put that into the bladder, and then about an hour later, you do your procedure. It does require special equipment because you have to fluoresce the bladder, but tumors preferentially uptake this photoporphyrin, and then when you turn on the blue light, these tumors light up pink. Where you see the benefit is in these papillary tumors that are small, but certainly in CIS. Again, randomized studies, high-level evidence has shown enhanced detection for papillary as well as flat tumors, the CIS, and those are game changers when you find them.
Yeah, I would certainly say, the tiny little papillary, if you miss it, you come back 3 months, 6 months, a year later, probably not a big issue. But CIS, a whole different story. So these technologies will actually help you identify the CIS lesions.
And so not only does the enhanced detection result in reduction in recurrence rates, but it'll be changing in terms of the recommended therapies for patients, like whether they get an induction course of BCG or a whole maintenance course. Some of these things matter, and so there's a lot of ways in which just that enhanced detection, which starts at the beginning, translates into improved outcomes for the patients.
I'm probably dating myself because I haven't treated bladder cancer in quite some time. When we used to do random biopsies, now you may say, oh boy, here's a dinosaur talking about bladder cancer. So will this, rather than doing sort of these random biopsies, and maybe that's outdated, is this going to actually help in terms of directing those biopsies?
It really does. So in atypical cytology patients, patients that have these persistent concerns but you can't find it, I can give you numerous cases of where you just turn on the light and there it is, and it makes the patient think you're a genius. All you're really doing is seeing something that couldn't be seen with the naked eye very easily. I think there's still a role for some samplings of extravesical sites, including the prostatic urethra, in these high-risk patients because it's not as easy to get that detection in those spots. But you're right, this has replaced a lot of that random guessing.
Now, how about one last thing? When you look at, because as you mentioned, when you have sort of this high-grade non-muscle invasive disease, you go back, you re-resect, there's often a disease that you thought were resected but wasn't. So do these technologies, when you go back to do your re-resection, one, do they help you in that setting to see if, or maybe guide the depth that you need to resect?
So in the bed of the resection, where there's no more urothelium, say 4 to 6 weeks, I don't think you get much there. But the perimeter, and you can actually use these technologies to resect with. So that was something that we did when we were doing the original studies. We would do some of the resection with white light after we'd identified the tumor. But if you resect in that fluorescent setting, you'll also get the perimeter tumor. But the biggest bang for your buck is say you have a 4-centimeter tumor that you couldn't miss with any light, but on the other side there's 3 areas of CIS that you would have completely ignored and not known where to go. So I think it does help do a better resection. Haven't seen the data on whether the re-resection will be minimized by that. So that's a good question, and I think that's a work in progress.
So do you think this will come to the office? Cystoscopy?
Good question. So at our AUA this year, we just completed a randomized trial using flexible office-based blue light, and it was a positive study with a 21% enhanced detection. Not only was it using the flexible in the office, but it also looked at whether you could do it in the face of prior intravesical therapies and repeated usage. And it was a positive study. The results are to be published, so I do think it's coming to the office.
So Dr. Cookson, thank you very much for all your contributions to the field of uro-oncology and bladder cancer, and also for bringing these important insights to Bladder Cancer Academy.
Thank you for having me.